AI is arguably getting close to being as good as people. A good portion of all of the routine discussions, all of the non-critical healthcare interactions could be handled by an AI.
We are going to go find out how these pain points are being solved, what those solutions look like, and how they're going to actually make our lives completely different on both ends. And we're going to do it together.
This is just going to be such an exciting time. And it's finally here. I feel like we've been waiting for this. Let's do this thing, Sanjay. We're going to do it.
If you've been listening to this podcast, then we have something very special for you. And if you haven't been listening before, then you want to tune in. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the OncDoc on social and news media, where we educate about cancer and everything that has to do with empowerment and bridging gaps. And lately, we've been talking about artificial intelligence and how it can really satisfy a lot of the kind of pain points that as a patient or as a caretaker or as a physician or a provider, you're like, ugh, it's just annoying that something that's recurrent, right? How do we address those issues? Well, the reason I say today is special is because we're going to break down really all of it put together. Why do we have pain points that continue to be pain points the next day? And I've learned a lot, and if you've been listening before, I hope that you've learned a lot in the last couple of years. We've learned things that have to relate with the advancements of cancer and how good our strategies have gotten. But the reality is, one phrase that still really bothers me, but now has finally turned a leaf, is the phrase that says, yeah, the cancer thing, when are we going to get on top of that? When are we going to find a cure for that? Or when are they going to figure that out? And you may get frustrated if you're in oncology because you realize how hard people are working. But the truth of the matter is, the second side of that coin might be, we have so much experience. We have so many cases. This thing's been around for so long. We have so many ways of documenting it now. How come we're not doing better? And that is how I receive that statement. It's like, yes, we have a lot of anecdotal and objective stuff, and yet we're kind of moving the needle. We may get advancements in a mechanism or, with CAR T, and we talk about those things on Target Cancer Podcast. But as a whole, how are we not understanding things better? And that is what this very special podcast is about, and with something that might be a little bit of a treat at the end, because if you believe in this and you believe in advancement in technology, then that's where we're going to go. We're going to solve the things that are problems. And today, we're doing that with my personal long-term mentor, good friend, and the gentleman that trusted me to become the host of this podcast that he started. And his name is Mika Newton. Mika, this is an exciting one for me because you have told me, Sanjay, the frustrations you have in the real world, do something about them. Let's figure it out. How do we make this better? And that's kind of what really started your entire journey in this.
Sanjay, I'm so happy to be here with you on the show. Again, by the way, I think this is a second time. I could not be more excited about the place where we are as a community in AI and technology looking at healthcare than I am today. I'm more excited. I'm also more concerned and in some ways more trepidatious about elements of it. But I do think what you're saying about the fact that we may finally be looking at solving some of the real fundamental problems that we experience in oncology, in healthcare in general, like that day is finally here. And I think if we take this next step in the right way, or the next set of steps carefully, we're just in a completely different world than we've been in before.
Yes, and we're going to get to those steps because somebody might be listening. It's like, oh, is it more of the same? Is it like, advocacy, policy, whatever? No, it's really unweaving and surfacing so much of the insight that we leave on the table. And that's what we are talking about when we talk about this word that means something different to me than it did a year or two ago. And the word is data. Now, data, when you hear that and you're just like, oh, this is not the thing for me. It is. Data now, if you ever listen again, means everything that's happening in the world today. Are we actually assessing the outcomes and learning from those experiences? Because realize any treatment you have, whether it's in cancer or rheumatology, but if it's standard of care, it was based on a trial, a study, a cohort. And I'm going to use a political example, and y'all know that I never talk about politics. But in this case, all of us can appreciate that when you vote a certain way, you are grouped into that. You're like, you believe in this, or that. And every one of us is like, well, no, I do it for this reason and that reason, right? We're all unique. Well, when you do a study or a trial, that is also just a sample size of everyone else that asserts, well, I'm not fully Republican or fully Democrat, and this is the reason I side with this, that, and the other. If you want that same application to your treatment and management on why you have this 45 to 60% chance of working, or why it didn't work when it was 85% chance, if you don't want that insult, and you as a person that's in medicine don't want to sustain the moral injury and the guilt and just the misfortune of somehow it feeling like your fault when somebody was in that 10% that didn't respond. That is what we mean by leveraging all of the things that happen with data and in this world today and actually getting insights. Continue the life sciences, continue the PhDs, continues the tech, do all of that. But can we figure out, once it's like propped up, launched, and taken flight, can we figure out more after the trials and after everything else to say, how do we tease this, out better? How do we leverage these technologies better? Can they work in other places? Because we have a very rigid, tight system on what is allowed and isn't allowed in what setting. And that is where data comes in. And that is that's your word, Mika. And it's an unsexy word, unfortunately, to use an adjective that may be a little blunt, but I think everyone wants it. Everyone wants to figure out how to use everything that we know today to just do better.
So let me give you an example of like the big picture that I get so excited about, and then why the data makes me really excited about it, and why it also gives me pause and, like I said, some trepidation. So if you picture that across the United States, and probably globally, that I spend a lot more time looking at the United States, we simply don't have enough healthcare facilities, enough doctors, enough nurses, right? Enough time in the day to actually care for everybody in the system. This is like a fact. So when I think we were first talking, I had been looking at some studies in oncology right around ASCO, where there's about 13,000 oncologists in the United States, and ASCO, which is the Society, American Society of Clinical Oncology, had already done a study and said by the year 2025, this was a few years ago, so that's next year, we're going to be short some 2,500 oncologists. Like, we just don't have enough oncologists to see the cancer patients coming through, right? That's really scary. That's a large percentage of missing doctors. If you look at nursing, and we all heard about this, after the pandemic and all the rest, all the people who were nurses who said, I don't ever want to do this again. They left the workforce, or they just gave up, or they got completely burned out, suffered mental health issues, all that. So my point is, we don't have the people, right? And if you're trying to go and see someone, I just went through this myself. It's a book. It was totally not a serious thing, but I needed to see a specialist. And it took me 4 months to get an appointment, right? I have insurance, it's in the right system, and it was because they were busy, right? And I had to get in a line and wait my turn like everyone else. So what if now we had AI, right? And the AI is arguably getting close to being as good as people. There's a lot of studies, and I went on and talked about this, that showed AI could be more empathetic than doctors, or could answer the medical exams, just as well. They've been testing the AI, LLMs against the medical exams. They're doing really well, right? Like, better than I had thought would be possible, certainly better than most people had thought, and they continue to get better and better. What if a good portion of all of the routine discussion, so when I had questions about my health, right, or just concerns about something, or I wanted someone to reassure me or talk to me, so all of the non-critical healthcare interactions could be handled by an AI, and you felt comfortable talking about it. Think of the multiplication factor for only using our valuable resources when they were absolutely needed, right? And you could discuss your case right up front. Should I go see my doctor or not? Yes. Do I need to really see this specialist? Yes or no? By the way, I can look at pictures and images and all that. So all this stuff, and then I could decide if I want to see him. And then, by the way, I get my diagnosis, and then I have some questions because let's say I have a reaction or something. What should I do? Again, talk to an AI. That is an incredible opportunity for efficiency. By the way, the only way that I can personally imagine that we are going to be able to deliver high quality healthcare to the entire population. I can't think of any other way that that's going to happen. So that's super exciting. I think it's here, but it also is really scary. And the reason that's scary is think about all the misinformation that we all know. Again, even going back to your point of like what I think is misinformation or the right information, like all of the human opinion about what's right and wrong, right? And having that train the AIs. That's why everyone's so worried about AI in healthcare. And like, what if it gets it wrong? What if we train it on the wrong information? What if it doesn't understand some bias? Like we've all had that discussion. And the only way I can imagine to actually get to the truth, and you said a really important thing about there's one study that says one thing. And by the way, there's always another study that says the opposite of whatever that study said. And there's another study that says something completely different, right? Because they're all in specific cohorts or populations and they study different things. But the only way I can imagine to get a general understanding and to have some hope that we're going to be doing good and minimizing the risks is actually to train it on reality, right? We have to look at the real things that really happen to real people over time. And the only way to do that is with this really unsexy, yes, it's true, data, like what really happened to people. And there's a whole lot to do around how do you decide what's real or not and controls and other components. But it truly means that data is the fuel, right? It is the underlying premise that is going to enable us to have this AI revolution. It just can't happen otherwise. So yes, data is unsexy. Yes, it requires you to get kind of geeky and think about statistics and a whole bunch of math and all that sort of stuff. But it is at the heart of absolutely everything.
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. That is fundamentally science. That is what you learn about. A null hypothesis, a hypothesis, and then see if it works or doesn't, or see what is actually happening. That is the application of theory and what exists. And that, if, that's such a salient point you make, start there. Use AI just to say what is and isn't happening, what is and isn't consistent with our standard of care. Where are we dropping the ball? Where are we not? Just look to see what happens. Does it fly? Does it not? Does it, that in itself fundamentally is science. I love what you said about also the reality, the stark reality about the ability to meet the needs in the country. When you said oncologists, I was thinking about my buddy Austin Chang. I saw yesterday. Everyone talks about, well, why isn't colorectal cancer screening 35 to 45? Because we know cancer is happening in the 30s, and we know it's early 40s, and we know it's not from family history. And he said it so simply. He was like, he just showed some numbers and was like, if it was down to 35 rather than in the 40s or 30 years old, it's just impossible given the number of GI doctors. So he's like, everything else aside, cost, everything else, there aren't enough hands to do colonoscopies at a younger screening age that if you took it down by 5 or 10 years from what it is today. And that's scary. So what that does is, when you take that reality, it takes something like 14 years from start to finish straight to be a gastroenterologist, much like it takes 14 years like a hemonc. When you take that, then the immediate need, not the it would be better, not that I prefer, the absolute necessary step is to ensure that things are brought to attention that require and necessitate attention. Like, that's what you have to do with limited resources. The people that need it need the resources first. How do you figure that out? The number of times I am texted, and what I do on a daily basis, is just a feel out from people that are in my index. Is this something I should worry about or not? Do I sit in the ER for 6 to 8 hours or not? Do I go somewhere else to another city for a referral, right? These are people that unfortunately have means. And I'm not diagnosing them, but I know the things that are concerning that I'm like, I don't suggest, waiting 2 months, weight loss for a few months, right? That's just like unexplained. There's some real tip-offs, neurologic things that I ask a series of questions. And then the other things that are comforting based on, a top 3 or 4 more likely diagnosis that fits comfortably. That's not rocket science, but it did take me 14 to 20 years to really be good at it. But it's algos, it's algorithms. Like, it's just, and it gives a nice little feel. I don't mean to reduce the significance of us as physicians, but it's triaging. Like, we have no triage of recognizing not just what, may not require immediate attention, but also what does require immediate attention that people aren't addressing. And those are two problems that do have one solution, but they're two very different problems. And I think that's where this, AI capacity helps, because the moment you're able to appreciate that someone's getting anemic or iron deficient and they're having weight loss, that's very concerning for colorectal cancer, pancreatic cancer, and the things that I know. It takes 2 seconds to know that, but most people may not. Versus somebody that's gaining weight, right, and still has fatigue, you have to triage it. Like if any of us want care when we have to have it, like, and not be like stuck behind waiting, this is the way to do it and come together. And I think that, beautifully illustrates to your point on the importance for all of us to be able to get on board with the idea of, let's make sure that people get utility when it's needed most. So that's the problem. Multiple problems. Now let's talk about how, because I get excited when you talk about AI and how it can help guide us. How is that going to be solved? So we have on one part data. You can't find out what's happening in the real world without that word, data. You say data, so now I'm going to change because you're a data guy. So you have to know what's happening. How do we do that? How do we figure out, how do we get everybody on board, or figure out, like, is there some, universal, like, acceptance? This will be the language we speak. Do we structure it and organize it in a way that's like the Rosetta Stone that can be translated by any point solution to then apply its machine learning? How does that work? And why should patients and health, institutions be excited or eager to do that for humanity as a whole?
Yeah, just great question here, and great opportunity. So when I think about how do we get data and what's going on in the world of data now, putting aside just AI for a second, I think we are actually at an inflection point in medicine, in clinical care in the United States, that's similar to the emergence of the internet. And the reason I say that is we've had government-funded, meaning taxpayer, our funding initiatives around what's called healthcare interoperability for over 20 years. It kind of goes back to the start of Hurricane Katrina, or when Hurricane Katrina happened, and a lot of people were basically displaced, right? And then we realized we didn't know what drugs they were taking or what conditions they had, and that was a real problem because these people needed to get back on their medication. It was a huge movement of people, right? And people were quite sick. And so we saw what's called health information exchange, right, at both local and state levels, and then even up at the national level. And we saw partnerships forming with the large electronic medical records companies, the Epic, the Cerners of the world, eHealth Exchange, which is more government. There's like a huge initiative over almost 20 years to say, hey, we need to be able to get people's medical records, which is essentially, I think of EMR systems as the ERP, or enterprise resource planning. So if you think about running a big company, what orders do I have? What are the materials I need to run my factory? How do I order them? How much stock do I have on hand? How much is in my warehouse? So in healthcare, I kind of think of that, at least in my mind, that's the EMR, is like, what's going on with these patients? What are the things we want to do for them? Right. And then there's other systems that are more like ERP, like, do we have the right drugs in here? Do we have the right equipment? But truly, from a personal perspective, your medical record is kind of what.
And this is different than a universal healthcare or socialized construct. Like, that's what I need people to understand. Like, there, for the most part, things are somewhat uniform and all in the same system. Because we're private and because it's business focused, however you want to say it, we have different ones. And that's fundamentally what I want people to understand, is like, it's the fact that different in a business side have popped up here, there, and the other. That's what makes this even more complicated than somewhere where maybe it was universal, EMR and everything else.
Well, even, and we can come back to this, even in the systems that have kind of the same system implemented, like different practices, you were bringing up GI versus oncology versus all, they all use slightly different languages. And if you think about the different types of things, you worked on an EMR for most of your career, there's like really structured data, and then there's just interpretations. I think like the text, the clinic notes that you write, where you're just describing what's going on, that's written differently by different people using different language, So that, to my point, is like, even when they're all the same system, it's all different people interacting with it, trying to capture different information in different ways. So the data itself is really heterogeneous, like it's all just mixed up, right? And different people working on it. So, and let's come back to that in a sec. The exchange, where I say there's like an internet of data that's going on, right, is these HIEs then turned in 2016 in the 21st Century Cures Act into an initiative around a common framework agreement and basically what are going to be exchanges. So if you think of like financial stock markets and the way that like data about stocks is exchanged, we now have, right, and this has only been true for like the last, I would say, couple years, working, functioning medical records exchanges that mean that when you go across different systems, the information in that medical record can now like transfer with you. And you can find out more about this at something called the Sequoia Project .org, which is run by the Office of National Coordinator HIT. And there's something called Q. There's lots of acronyms because it's healthcare. But just think of this as like medical records can now move around pretty freely, given that you have the right permissions and the right uses and the right security. Okay. Why is this like the internet? When I think back, and I'm old enough that I grew up without the internet, and then one day I went to the library and there's a thing called the internet. It had like a couple hyperlinks and I could look at a research paper or something like that on it, right? And I was like, I didn't understand it, but it turned out to be a huge thing. So what happened? Well, before the internet happened, everybody had like private connections. So if you think of like running a company, you had a connection to your bank and maybe you had a connection to your suppliers for stuff. And those were private connections that were created and set up by someone in your IT group, and the computers talk to each other, right? It wasn't just paper going back and forth. When the internet happened, the people who really figured it out, right, and that revolutionized everything realized you could do business with anybody. You didn't have to know them beforehand, and you didn't have to go and invest a lot of money and time and energy in making this like one place to one place connection, right? It could be anybody as long as they could connect to this internet thing. And all you needed was like the software platform, the tool, the technology, and security, and like lots of stuff had to be built. But once it was built, everybody could use that same kind of central protocol resource utility. And now you could do business with anybody. So now we have, I mean, imagine a world today. You can't even imagine living without e-commerce. Like everything shows up at my house in a box, right? Because I talk to a box on my table and tell it what, Amazon should bring to my door or whatever. Like that's how it works. So that is now suddenly possible in healthcare, right? Meaning the information can move around, right? I think we're just figuring out the security protocols, right, that need to go in place and who should have access to it, because just because it can move around doesn't mean that everybody should be able to connect to it. And we see all those same problems exist on the internet, by the way, of like bad actors, right, hackers, people trying to like commit fraud. Like it's all the same stuff, right, that we have to be protective of. But it does mean that we now have an opportunity, if we build and do that, to have everybody interact with everybody all the time. And going back to that kind of like, how do we know enough? How do we get enough data about people to really understand what it is? That was never possible before because the data was only in the point-to-point places, right? That was the only way you could get it. So the only way to get everybody's, even one person's data would have been to go and make 30 point-to-point connections for one person and then go get to your point about that, colonoscopy, it just wasn't even possible, right? So in my mind, this is like, I always have like this feeling like an explosion in my brain where I'm like, it's all there. How are we going to make it work? Like, what are we going to do with it, right? How are we going to make it work? How are we going to make sure that we go after the right things first? And then really importantly, like if we have an internet, like someone's got to make search engines and browsers, right? And then once you have search engines and browsers, someone's got to build marketplaces and shops and build like new apps on. Like, so I just think this is going to be a completely different world going back to where we started, which is going to address all of the things like disparity in care. I'm going to make one more point on this. I went to a meeting called the Canopy Collective meeting maybe a week or two ago. The Canopy Collective is an organization that ties together the leading pancreatic cancer institutions, right? Because pancreatic cancer is a horrible diagnosis, really hard to treat. And it's like the experts in the entire space talking with each other, sharing and collaborating around patients who can learn from the best. And it's got like 14, I'll get the number wrong, some fairly large number of the leading, treatment centers in the United States collaborating on it and sharing data information. I went to dinner, and at dinner, there was a pancreatic cancer patient who was there as a patient advocate and her friend. And I started talking to her friend about this. And her friend told me that she lives in Nevada, out in like 4 or 5 hours drive, right, from any sort of like healthcare facility. And we stopped talking about pancreatic cancer. She just started talking to me about the people who live near her in her community, right, which is a much bigger community. I live in a city, right? So I'm used to people being close. Like your neighbors are far away when you're out there, and how they could actually get access to any sort of healthcare. And they basically don't have any. They don't. Like once you kind of pick that piece apart, you're like, you guys don't have access to even primary care, basically. You got to drive 3 hours to see a primary care or have somebody drive around and maybe set up a clinic. It's just a very different world. And I think that, again, we're just right at the really beginning of being able to do something about this. And I think the same, by the way, is going to apply in all across the entire world, right? And we are not even touching things like emerging economies, right, or other countries where they have almost no infrastructure.
Yeah, I mean, that it paints a beautiful picture. And that's like the kind of solution aspect of this. That's why people get excited with that said painted picture, is that things can finally be done differently. And I'll give you an example. And you said it with the iPhone or the phones. We live in a world today that when you have your iPhone and you download Google Maps or Waze, you don't have to manually like go to a map and figure out where you were, like where your location is, and then add north, south, east, west. It just knows where you are when you share like your location, and then it also knows things relatively in real time and predict on predictiveness or predictability of like where the traffic is, what to bypass, where there's been a road closure for the past week. The same thing applies when you pull up your weather map, right? It's able to tell you like what the weather is. The same thing applies to when you open up your Netflix or Hulu or Instagram. There's already these things that what to watch next and things that are of interest. They're not the same things that when you go into an Airbnb and it feels so oddly intimate when somebody else's account is opened up. Why does it feel so intimate? Because those selections and everything that's not on your Netflix selection page is that person. That's their identity. That is their, and I don't know, maybe it's just me, but I feel like I'm truly in someone's like home. And it really has to do with the precise things that applies to that person. Now take this concept. If you can quote unquote feel that, like you see what that means. Like when you go to someone's phone, you can just kind of tell, even though the apps aren't really, you didn't draw the apps, but you just have an idea of the climate. Imagine that you had that with your healthcare, so that when you go into a system, it's not like you got a brand new phone that's not uploading from the cloud. The uploading to the cloud and downloading everything from your previous iPhone is the continuation of everything that you've had before, starting today, rather than having a new phone and like, okay, now we're going to order these molecular, this, that, and the other, and there's no context. And there's no like, kind of like, okay, you do need to go get this because you didn't get a colonoscopy in 10 years and you're anemic versus not. It's a blank page versus having everything somewhat oriented and aligned in a contextual fashion. And so you can imagine how much faster it is to get to that destination when you know where your spot is and it's already assessed the stuff for the past week. You could imagine how much quicker it is to find something you want to watch because it's already had this retrospective kind of context in where to proceed next. And I hope that lands as you think about that, because right now, without that, it's blank pages. And so how can you think about a more intentional and precise care and direction of care rather than being lumped into 100 phones? Because if you've been to the ER and they just ordered a CAT scan or they just ordered an x-ray or they said it was gas, if you are getting a rote and primed kind of same statement and you went into 3 different ERs, that's the consequence of no context. That's the consequence of a new phone where you just have to download the mail app and you're just going to continue to do it every single day because you're not given a phone that already has all the contextual relevance ever. And that is why we get excited about the solution, you and I, on our background chats on Friday afternoon and on the weekend, because you can take everything that you have and bring it forward prospectively for every point. So it helps you as an individual. But then when we get really excited and where the solutions are happening is it can also fertilize that with what we know in the real world. And it can know your point in that real world based on what's happening and what is being done and not done. That's being, that standard of care, much like knowing at that moment where you are in your route to your destination on Waze. It knows at that moment where there's the cop, this, that, and the other. And I'm using that example a lot, but it really fits pretty well into that case example. So just, in full disclosure, I do AI operations at Tempest, and this model we have, this clinical decision support for non-small cell. It's like finally there's something in the background that is bringing a contextual relevance to where you are with your lung cancer and what mutations you have or haven't been tested for that could actually fracture your possibility of getting the right therapy, right? So you can imagine having that for different kind of cancers. It's an extra layer that gives context to an otherwise blank phone every single time I refer to you as a specialist. And then if you could build that out for rheumatologic disease or, inflammatory bowel disease, and you're not a blank paper every time, now you get further along because, oh, this stuff's already been done. This stuff's already been ordered. This stuff has happened since then. All of that happens only with data. And AI, there is no AI, there is none of that context every time without data. That's mutually exclusive. No AI, no assistance, continue being in the place that we're at today unless you have data, because that is the relevance. That is the cloud upload onto your new iPhone 15 when you had the 9. Otherwise, you're starting back at scratch. And we don't want to live in a world of scratch.
No.
And that's where we talk about now. Let's talk about, and to the point that you're mentioning, and I'm sure you're going to make now, what that looks like going forward. So we talked about the problems. We talked about how it's a blank slate. We talked about how we're not learning from the real world cases, which at the end of the day is science and what is and isn't fact. What does a world of data and thus the ability of having AI to assist us personally as well as physicians look like, and what can it bring to us in this world moving forward?
So I love the Waze example. I love that whole like traffic example. And I think, right now when I get in the car, let's talk about the future. When I get in the car, I type in the address where I'm going to go, even if I know how to get there. You know why? Because it sends me there on the best possible way. I actually know that any place I want to go, there's probably like 5 or 6 different ways to get there. I don't know what the traffic conditions are like today, and I don't know what's going on. And so even for like local things in my like my immediate neighborhood, I still type in the address, right? Because I'm like, I want to go the best possible way. Now, what that brings out is a really interesting thing that we don't really think about. And this, by the way, takes me all the way back to like one of the reasons we founded xCures, and we think about continuous learning and optimization, right? All the time, like very core concept here. There's a concept of coordination, right? Which says that the participants of doing anything can actually achieve a net result that's better, right, than any one of them could achieve on their own, as long as they coordinate with each other. So like if you think about the traffic example, which is a great one, like if everybody goes on the shortest route, right, in distance at the same time, that route is going to have the worst traffic. But if some people go on a route that might be a little bit longer, enough of them, then both of those routes now are going to be open, like are not going to have a traffic jam. So instead of everybody trying to go the same way, it's actually important that people split up and go in different ways, because that optimizes the use, right, of our roadways, right? And that's something that most people didn't really think about. It took me a while to figure out, like, why is like my driving app sending me one way one day and then another way the other day? And by the way, I'm generally not experiencing traffic the way I used to experience it anymore, unless it's completely unavoidable. And it's because I'm actually coordinating my driving with the local conditions of whatever that's going on and all the other drivers who are also using those apps at the same time. And so that's happening. But then if you zoom out, and I was actually talking to someone, this was very interesting. I was talking to someone who works in the ambulance world, right? And they do coordination and data around ambulances and how ambulances get deployed and where they drive. So think about now there's a critical car, right? In this case, truck that needs to use that route. And they want to know a couple things. Number one, given any particular time of day or situational set, like what's the fastest way to get somewhere that's the safest, that has the right roads, right things. But also, how many ambulances do we need to have for a Friday night at 10 p.m. near this roadway? Because they actually know now from all that shared data and information, you actually understand where these situations are like percolating up. So thinking of the future of healthcare, like, again, we go back to this kind of resource limited utilization regimen. We probably have more resources than we realize we have because we haven't optimized, right, the coordination use of those resources most effectively across that. Whether that means we actually have enough resources or we still need more, I don't know, really. I think that's probably something else to think about. Is there's like additional, where would you add more resources? But if we could just reuse what we have or use it more efficiently than we've done, and I suspect it would address another fundamental issue that kind of sits below when we talk about resources, which is costs. So, and I've seen, I don't know how many studies, right, that show like the United States has like the highest cost of healthcare in the world, right, and like not the best. And then everyone says, well, yes, but some of ours here is the best. And then some people get the worst, right? So as we look across that entire spectrum and we start thinking about how are we going to be able to afford our healthcare, right, and afford, right, and address some of the disparities that we see for just everybody, like everybody in the country, it's going to be driven by money and access, right? And those things are fundamental to me to the operation, right? The operations of healthcare and where and how we deploy resources. So I think your Waze example, right, is like, we already figured that out. And yes, we're still bad traffic jams, and sometimes it's unavoidable and all the rest of it. But I'll tell you, driving got a lot better. I used to print out the little paper maps, right, and have a map book in my car and like get around. And I'll tell you, I was lost 99% of the time, right, or didn't have the right map book or whatever it was. So I think that resource utilization is going to be huge. The other future thing, and actually I was wondering, this is something I wanted to ask you about, right? I often hear people talk about like going to a doctor and trying to understand like, what did other people like me do and did it? It's like this fundamental question of like reviews. So think about Yelp or like any, reviews website you might go to where you're like, hey, is this a good, restaurant to go to? Is this a good hotel to stay at? Right? Should I watch this problem? And the data that's input into that, right, is data from other people who've stayed there and done that before. The problem we have in healthcare is it's really hard to understand that. And we looked at this a little bit in our company for a while, this kind of cold start. Like, how do you know what's good? Sanjay, is this the doctors who need to like collectively come together? And do you need to program these things with like the best knowledge? Like, how can you imagine as a doctor that you would actually be confident that it wasn't, if we're going to do all this coordination learning, like how do we know it gets built right in the first place? That part,
So this is a great question. It illustrates a great point. And that's, in a weird way, we are conducting, an individual physician is conducting their own, study, right? They get their own case studies and seeing what works and what doesn't work, one person at a time. That's why experience is something that oftentimes people want with chronic illness, whether it's neurologic, rheumatologic, oncologic. They want someone fresh enough to know what's current, but they want someone with experience. And the experience is for the observational awareness of what, happens or doesn't happen when you do X, Y, or Z. And to your point, it's like, where's the guidance of saying like, wouldn't it be great if I knew what was elected for what percentage of the time, the aggregate of what decisions somebody's making in a gray zone that is the same kind of specialist as me? And to answer your question one step further, that would be the aggregate. You're like, well, Sanjay, what do you do for the, do you pick the specialists that make, this, that, or the other for this specific, case or point? I would argue with you with exactly what you said earlier. What really matters, I might be narrowing, within the humility of, the human mind and what we know and what we think we know. The way you kind of dissolve inherent bias or maybe going down the wrong path is volume and real world evidence. This, again, like what's happening. So you could go ahead and train and compare a group of specialists to the general population, but really what ultimately matters is the decisions that are being made. Where do they fall for the endpoint? And the endpoint would be you fixed that one thing or you didn't. But secondly, there's all kinds of downstream metrics, like how much did it cost? How much time did it, was it spent? Was the workup overkill at the end of the day, right? Because the specialist might say, oh, you have to have this. So you learn a lot of things in that capacity, but I think always having a comparator arm of what is happening with people, sure that you can select to, some degree geographically or whatever else, is always good. And then we can train different AI solutions and models based on comparing the specialists, decision making that's only between 10 wise women and men into that concept. But I want to go back to what you were saying before, which I think is beautiful, and that's the utilization of resources. Everyone knows of someone that said, I had been to an allergist, immunologist, a GI doctor, a neurologist, and now I'm with you. And I'm sure some physicians in a burned out system are like, well, like this is not going to be diagnosable. For me, it drives me like, what a sad reality. What a tragedy that somebody's having to get ping ponged around. This is a great demonstration of how AI can change the future. Because at the end of the day, and I pride myself on being the person to either like navigate it to the right person or solve it if I can. At the end of the day, each specialist is looking at the objective criteria that's been ordered and imaged and your history and saying this does or doesn't fit in my box of potential diagnoses. I think you need to see an X or a Y or a Z. And that's very frustrating for patients. It's very time consuming and it's financially toxic, like to the system and to the individual. Imagine that you could have a refined, tighter ability to know where to navigate. Even if it's a list, even if you shuffled that around to just increase the likelihood of who to go to first matters. Because I see several patients that have seen multiple specialists and they get referred to me because their immunoglobulins like IgG, IgM, IgA are all high or their ferritin's high. Now, that happens in inflammation, but they'll send it to a hematologist oncologist thinking there's a clonal problem or something that's wrong with whatever. And I won't leave it at this is not my problem. These are all up in the setting of inflammation. It's polyclonal, which is generally not a cancer thing because cancer is monoclonal. But I'll say this is what really tells me you need to go to, say, a rheumatologist. Have you been to one? No, I've been to everyone but rheumatologists. But to me, it's a no-brainer because the ferritin being very high, not meaning stored iron, but inflammation, plus a bunch of the immunoglobulins, to me as a hematologist, I can appreciate that this is a pro-inflammatory state. Or it could be inflammatory bowel disease or whatever. But I'm doing that based on my knowledge. Like I know that, right? And sometimes I wish they came to me first because maybe I could have made it tighter, like on the likelihood of success for the next specialist you get sent to. That all of that I just said is AI. Like that's the bread and butter for AI. Like they're like, bro, I got this all day. Like, put me in, coach, because they can know what ended up happening, what the workups were, what the diagnostic, events were, and what eventually led to the diagnosis. You give it the data on what was the diagnosis and what ruled in, ruled out, which we could do you and me in 7 seconds. Not me physically with the tech, but you could solve that instantly, and you would have saved that person 6 months, financial toxicity, psychological insult, frustration, loss of hope, all because the order by which the consults were facilitated could have been better. And sometimes it's a capacity issue. Sometimes it's easier to get into, say, a neurologist than a rheumatologist, and therefore you're just going to hope that the neurologist does it. None of that should be a factor in care. And that is where I see, again, to this whole concept of context of like, it's not going to replace the doctors, but it's going to make sure that you see a doctor and when you do, that it lands, that this is like a good chance or likelihood of success. Because at the end of the day, like I said, you always say you want someone with experience and somebody that's up to date. Well, we already know the capacity of AI on, I believe they said something like 7 days it could read all of the internet, where it would take a human to the same degree of recall, 200 years, 24/7. So that's a fact. You can test that. I mean, you can't test a human learning for 200 years, but you just know they can't do it. And so why wouldn't the same knowledge and metrics on your ChatGPT or Gen AI, when you ask it something and most of the time it does something accurate and gives you exactly what you're looking for, if you characterize it well enough, which is prompt engineering. I think we overcomplicate AI. You need to be a prompt engineer, this, that, and the other. I'm like, dude, don't think like that. Just say, give it all the context it needs to get the highest likelihood of it, the answer. That's what you're doing in ChatGPT. We know we could do that. AI, science and medicine, for the most part, for most people, 98%, I'm making that statistic up, of the cases are straightforward and actually just require somebody that's read the stuff. The same person that's read the 200 years of the internet versus the ChatGPT. Do all that. And then imagine the 2% that actually gets facilitated very quickly to where they need to go. But the 98% don't have this complete, primary care first and then into cardiology for clearance. Does everyone need cardiology clearance? We live in a CYA. It's called, surprise, cover your ass medicine. It's like, they may not do it even though there's really not enough risk factors. And I'll ask the question, why are they, wanting a clearance that takes 4 weeks to see the cardiologist? You just do it to do it. But there is an easy assessment based on your, heart condition, with your echo, with your blood pressure, with the meds you're on, your weight, all of that, to where, you just don't need this. Like, don't monopolize a cardiologist like for this because the likelihood is so low. And these are the ways that truly I can't imagine one, the sparing of the financial toxicity of the healthcare system, two, better satisfaction, not just from patients and families now, but even this burning out principle that nobody wants to hear us say. Nobody. It's like, shut up kind of, thing. But it's
Yeah.
truly like it's getting overextended for so many reasons. The tenacity or the will or the attention, that even that would be so much more fulfilling and rewarding, because I don't have to take the insult of the frustration from the family that is justified to hear again, this is actually not a hematologic or oncologic problem. Like I can't imagine, but I will do everything I can to help my moral injury, but to help them. But it's just, if it's unnecessary, what are we doing, y'all? Like,
So,
like we have AI that can actually help with these processes. And so your passion is on the data piece, which is how do we make sure that to get that insight, to get that facilitation, to get that priority list, that everything is done cleanly and tightly, in hope that that is the way, world we live in 10 years. And then you have all of the AI people that are saying like, I have a solution for this or for that or for this, right? Like people, I love the wearables example, where why wait till your saturation is 80%, normal being 88 to 92% or above? Why wait to then show up to the doctor when you have all these symptoms and stuff and need intubation and a low chance of dying? And then everything to do with intubation, deconditioning, infection, all the other reasons you can die now. Now, that same walk up the same flight of stairs that you go to work every day, your watch, or even your Apple Watch actually has the technology to know is putting a strain on you that, like Waze, that today's not the day, that the traffic's just more, just trust me, something's up on your cardiorespiratory, ability, that this should not take you, require this much effort. And now I've gotten a tip off to, in that early pneumonitis, in that early stage of like respiratory failure, to hopefully then get the antibodies if it's COVID, or to get, the flu, whatever the empiric treatment is. Or in this case, it wouldn't even be empiric because you would know and you'd start it before you went into respiratory failure. That is one very simple example. Neutropenic fever, right? Sepsis, all this stuff. The heart rate's already going up, to a degree. That's SIRS criteria. That's the first criteria before sepsis. I am a bunch of algorithms, Mika. Like, I know all this stuff because I've studied it and done it and immersed myself, and I just can't show up to work unless I know this stuff really well. But they're algorithms. And it's so possible and processable, if that's a word, and fast, like in a quick rate, to where then when you come to me, it's for the stuff that isn't algorithmic based, which is 99% of my triaging and directing in the right, in the right,
gotta
direction.
get out of your head and get it into practice.
Yes.
So I got a question for you around this, because when you and I first met each other, like one of the concepts that we talked about very early on, and I just don't hear it as much anymore, is this like Dr. Google phenomena, right? And we were talking about like really sick cancer patients and them coming to the doctor and they have something that they found on the internet somewhere, right? And, 99.9% of the time, it's just like they didn't understand. There's a research paper from some obscure place talking about some thing that worked for one person. Like, it was weird stuff. And I talked to a lot of doctors actually at that time who were like, they would roll their eyes about Dr. Google. And then I talked to patients who were like, but that's where all my information comes from, right? Like, why do... And every now and then you get a story of someone who did find something from Dr. Google that, by the way, saved their life. Like, those are real stories too. So, and I know you talk to a lot of physicians, right? And you've talked to a lot of technologists, and probably a lot of them are into tech and all the rest. But do you think like the physician community is going to really be ready for this kind of AI that we're talking about? Are the people who this is going to do the most for, I think, right, in terms of their professional day-to-day life? That's something I really believe. Are they ready for this?
I will tell you, and maybe I'm a little biased, but true fulfillment comes, and true reward comes from doing something that, like, you can call it your own, right? And if a lot of what you're doing is placating or explaining why it's not you, or explaining like this, that, and the other, it becomes rote. And I think we're going to totally re-examine what we consider necessary and unnecessary with AI. Meaning, like, I do a lot of hand-holding, and I don't even like that term, because I think everyone deserves to know and be oriented and understand and appreciate why I'm saying what I'm saying. It isn't cancer. It is cancer. It's going to be okay. It's not going to be okay. But a lot of the things, the reward comes in the puzzling cases. I talked to my wife, who's also an oncologist, Lauren, who you know well. I told her, Lauren, I think the reason that I really got excited about the cases that actually weren't cancer, but truly like there was a problem, is because it was outside of the routine for me. So I could do non-small cell all day. I can do lung cancer, colorectal. I know the spiel. I'm giving it all the time. Like it's become routine to a large degree in a first line, second line setting. But the thing that's a puzzle, like I think I went the extra mile because that got to revive me a little bit. It got to actually do something that's not so obvious. So I have to believe that nobody likes rote and routine work in any capacity, forget if you're medicine or not. But the stuff that you feel that you did something and navigated, like that matters, right? And in a perfect world, I would be able to access and retrieve every bit of information I need to make that circumstance correct. So if you look at my desktop, I have like so many tabs open, and I'm getting faster and faster on where to retrieve what and how quickly. Control F all day, every day. Gen AI in itself, if I could have it in one box, right? And then you talk about superimposing the retrieval process by also having access to the patient's records. So I can say, did they ever check like for vascular circulation, like could it be like a celiac artery obstruction? And it just tells me instead of me clicking radiology subcontext, go through all the radiology reports, see if they commented on the celiac artery. That's what I have to do every single day. But instead, I can actually retrieve it and say, and if they did, then XYZ. It just makes everything faster. And so that's why I do think there's just more reward and more, juice from the squeeze to be had, because we have to squeeze really hard just to get the variables, details, and insights to deliver what 98% of the time could have been very straightforward. And it's for this reason. It's for everything that we have all talked about with you, with every guest that I've had, when it comes to how things could be done better, less frustratingly, and more rewardingly, both for the patient and for the providers, that we're going full court press. And we are going to go find out how these pain points are being solved, what those solutions look like, and how they're going to actually make our lives completely different on both ends. And we're going to do it together. We're going to be co-hosting and calling this podcast AI and Healthcare. How can we have the frustrations go away? How can we have the things that we're just almost giving up on actually happen? And it starts here. And if anyone has experienced a pain point or lack of hope or a lack of belief that things can get better or less frustrating, this is for you, because the way we move that needle even a little bit faster and quicker, 2030 versus 2029 and a half, is by putting it out there. And so we're going to get the people that are just wizardry when it comes to like, this is what you can do with data. This is what you can analyze. This is how a patient can go in and be a boss and knows exactly what to say. And this is how literally the thing that you've been fearing because it happened in your mom or your dad or your family members or some, prophet told you like in New Orleans, like under a sky globe. These are all the things that you can do to get insights and be ahead of the problems that you may feel that are inevitable, because we have the capacity, we have the tech, we have the data, and we have the science. You just got to bring them all together. And that's what we're going to accomplish here on AI and healthcare, basically the healthcare of tomorrow.
I'm so excited, Sanjay, about what we're going to be doing right on this podcast. Just kind of thinking a little bit about the future here, because I think these questions of like, how is it going to happen? Who's going to do it? What should we do first? Why is it really going to matter? Who's going to get access to it? What money is it going to save, right? Or whose lives are it going to save? Like, I just feel again, like we're sitting here at the beginning of something that I think is as big in healthcare as the internet was to e-commerce and shopping, right? And like, we're going to get to go on this amazing journey, right? Of understanding all of this stuff and talking to people who I think over the next, and by the way, I don't think this is like a 20 years to achieve it anymore. I think this is all going to happen in the next like 5 years is kind of my personal bet of like 5 years from now, we will look back at what we were doing and, going into 2025. So we should probably just say 2030 and be like, I can't believe we were even debating this topic. So I'm super excited about it. I think we're going to get some great guests, right? There's a lot of people with a huge amount of expertise in this space. And I think, this is just going to be such an exciting time. And it's finally here. I feel like we've been waiting for this, like I feel a little bit like, a kid on, my family celebrated Christmas, like Christmas morning, like all the presents are there. And you're like, do I even want to open them? I'm like, no, I just want to look at them. I'm like, no, I want to rip them all open right away. So it's like super, super exciting.